So one of the key questions that we've had facing medical imaging is, can we make the diagnosis of concussion in a single subject? That's the holy grail. So I think we're coming closer and closer to that, and I'd like to do some, or present some information about how the brain blood flow regulates, regulates blood flow after a concussion, and whether this could potentially be a marker for someone with a recent concussion. So I am conflicted, but it's a good thing because this device, this Respirac device, allows us to do something that almost no one else in the world can do. And what that is, it delivers a rapid, sudden stimulus in carbon dioxide. So what good is that? And what it's good for is that CO2 is a powerful vasodilator. And when it's given, and when given quickly, your brain arteries, instead of going like this all day long to neuronal activity, go like that. So I can test the entire brain vascular bed very quickly and precisely. The stimulus is quantitative, precision, and reproducible. So I'm going to review the relationship between cerebral blood flow regulation and concussion in this talk. And the important thing is to remember that the brain has virtually no reserve for energy storage. So if you were to suddenly stop brain blood flow, like I know some anesthesiologists did with a blood pressure cuff exceeding systolic, patients were only conscious for 15 seconds. So the brain constantly needs blood flow. And the problem with resting blood flow and not stimulating the capacity of increasing blood flow is that you're going to find out if you review the literature and you look at resting blood flow measurements, they're not sensitive enough to determine the presence or absence of concussion. So what happens when the brain is perfused by abnormal vessels? Well, ideal in a lot of my patients have large vessel carotid stenosis, and the neurosurgeons and neurologists want to know what's the impact of that. And we can use CT perfusion methods, but there are problems with those methods. We think that the ability to vasodilate and then look at the response distal to a large vessel stenosis has the potential to be more accurate than conventional non-stimulation resting cerebral blood flow methods. What happens if then the blood flow is insufficient to provide the needs, the metabolic needs of the brain? And what we think, that's called neurovascular uncoupling. And if the metabolic requirements aren't met, then you're going to result in a situation where the energy demand is, the support for the energy demand for increased brain activation is not there. So if I start tapping my fingers and the blood flow doesn't increase enough, what happens to the brain under those conditions? And what we find in patients who have an acute stroke, the brain dies. That's a complete cessation of blood flow. But what happens if there's just chronic, low-grade, insufficient supply of blood to the brain because of a stenosis? And what we found is that the brain cortex thins. We found that there's a decrease in fractional anisotropy in the white matter subserving that brain. And we now know that NAA could actually be an important feature in preventing accumulation of amyloid fibrils. So this is an important issue, not just in terms of immediate brain function, but function down the road. And then we know that there's progressive loss in neurocognitive function. That's well demonstrated in these people. So if they've had a stenosis and they're not having acute strokes every day, which they don't, they have the stenosis and they live with it, slowly the brain seems to be losing function. Okay, so a little bit of control of brain blood flow. There's myogenic regulation. What that means is if your blood pressure were suddenly to go up, the brain, what do the brain arteries do? They do this. The muscle in the wall of the arteries contracts so that the blood flow is maintained. It's not going too high. What happens if your blood pressure were to drop? They suddenly, by reflex, open up to maintain resting blood flow. Then there's neurovascular coupling. Neurovascular coupling is local modulation of blood flow by active neurons. And that's good because too much blood flow is bad to the brain because it gets oxygenated, and when it's oxygenated, free radicals develop, and that causes injury. It can cause injury to cell membranes, cell constituents, and DNA. What happens if you don't have enough blood flow? That's ischemia. The same thing happens. Free radicals are generated during ischemia in the brain tissue. So these are the bad things. And we often wonder now if someone with acute concussion should be treated with agents that can prevent free radical generation. And then there's gliovascular coupling. I'm finally seeing great work being done on understanding what's happening with glial cells and the impact that injury has on those cells in maintaining brain homeostasis, which is what their primary function is. So they look at pH in the environment, potassium in the environment, glutamate in the environment, and with all of these fluctuating constituents in concussion, they're trying to modulate the excess in development of some of these things to prevent further injury in the brain. But I think these glial cells get overwhelmed. This is an area I never knew about until, a few months ago, this autonomic innervation of the brain. And there are brainstem nuclei that send fibers to the brain. And what's amazing is these are the longest neuronal connections in the brain itself, if you look at these images. They go everywhere from the brainstem to all segments of the brain. The only other fibers that might be longer are the ones that go from your pyramidal cells in your primary motor cortex to your anterior horn cells in your spinal cord. Those are the cortical spinal tracts. But you can see these nuclei can change blood flow, and they modulate blood flow. And the length of these fibers needs to be considered in future research with regard to blood flow regulation, because if they're the longest fibers, they're the most vulnerable to forces exerted on the brain by traumatic brain injury, because there could be several areas in those fibers that are impacted by shear forces and tensile forces that could disrupt them. So if those fibers are disrupted, we may have a problem with blood flow regulation just based on that alone. So there's a great paper that came out. This kind of describes the whole scenario. Here we have the pial vessels on the surface of the brain, and they're innervated by ganglia in the neck and at the skull base. And these are autonomic ganglia that will basically control the flow through the pial circulation of the surface vessels on top of the brain. Not so much in the vessels here, which only modulate brain blood flow by about 5%. These are the carotid arteries and vertebral arteries. These are the pial vessels, and we know that they control flow up to 50 to 2/3 or 60% of the flow that goes to the brain. Then there are the intrinsic vessels in the brain parenchyma itself. And look at this. This little green cell down here is sending fibers, and these fibers just don't go haphazardly anywhere. They're connecting to blood vessels, they're connecting to glial cells, they're connecting to other neurons. There's an intricate mechanism to control brain blood flow. So, interesting, you look at the literature on this and you find papers that say this. Norepinephrine, or noradrenaline, produced by the locus ceruleus in the brainstem, enhances temporal coupling between oxygen demand and supply. So this loss of these neurons, like you can see with Alzheimer's disease and Parkinson's disease, leads to delayed hyperemic responses. You get hypoxia, reperfusion, like mini injuries potentially in the brain. Can you imagine chronically experiencing these energy deficits in the brain over time? So the accumulation of such events, they said, over time may promote ischemic damage and hasten disease progression. So we've seen a lot of data presented, and we see group data. We see that groups of people, in one condition we measure, say, with fractional anisotropy or connectomics. You take healthies and controls, healthies against concussed, and you see differences. But are we good enough to see differences in single subjects? For the question that was asked earlier in the meeting, which was, my patient hit their head. Is that significant? Can we image that? Do we have a blood marker that can test for that? So what about CVR assessment in concussed individuals? You look at the literature, and what CVR is simply a change in blood flow for a change in stimulus, and this stimulus can come from neurons, changes in blood pressure. We give carbon dioxide, and we do MRI to measure this. That review of literature shows decreased CVR, another one with increased CVR, another one with decreased CVR, another one with decreased CVR. A lot of the differences in the literature are because they're not using a precision stimulus. They do not know what the arterial carbon dioxide concentration is in the brain, and that's what our device allows us to know precisely. So we use that device here in an MRI system. It's called prospective targeting of arterial CO2. Our CO2 targets that we set with this device are equivalent to arterial carbon dioxide levels. We've done this in animals, we've done this in humans, and we can do blood gas measurement non-invasively if you're breathing on the device. We use a 10 millimeter step change in carbon dioxide. So Alan Much is a colleague. He has one of these devices in Winnipeg. He studied patients with concussion. And this is about single subjects. And he had adolescents, sports-related concussion. He did perfusion measurements, which is how you measure blood flow. Didn't see any changes. Then he measured CVR and found, unbelievably, because I never would have expected this, that CVR is increased. The only time we've ever seen increased or supernormal physiological responses is in patients with obstructive sleep apnea, which now has been verified in another group. What he did was he simply looked at how many standard deviations beyond normal his CVR values were. Here's a normal distribution. He looked at this red distribution. Here's a single control. You don't see red. Here's patient 1. Here's patient 2. You see a lot of red. I mean, you can look at the image and say, those 2 patients had concussion. How good was this, though? Well, we do standard ROC analysis. So this is the best test we have in medicine, testing for blood glucose. This is a receiver operating characteristic curve. The best test should have an area of 1 under that curve. And that's exactly where the blood glucose test is. How good was his test? It's this one right here. He found that he had a 0.88 area under that curve. Now that's really very good. That's a good test. Did we improve on that? And so just last night, my postdoc, Rima Shafi, who has a poster out here, and she'll be discussing male-female differences and some data I'm going to present subsequently, sent me this data. I added it to my presentation, and I'm going to show it to you now. So the way we do it is we have a step change in CO2, 10 millimeters of mercury. This happens in one breath. It's rapid. And you can see the Untitled CO2, which is really arterial CO2, is a step change in the arterial blood. This is the brain's response to that. You see, the flow response is a very slow exponential curve, and it's maybe bi-exponential. We're still exploring this issue, but we're modeling it as a single exponent. We convolve that against a multiple exponential waveforms. So then we look at the final convolution result, and we get the exponential curve here measured as this parameter tau in the equation. Tau simply represents speed of response in seconds. We do it in patients with carotid vascular disease, and this is an incredible image because what it's showing is in this patient's entire brain, where is the tissue perfusion the worst? Where is the energy crisis going to be the worst because of loss of vasodilatory capacity? And it's in these pale blue areas. Okay, so that's with big vessel stenosis. What about the small vessel issues that are happening inside the brain parenchyma? Well, you can look at this tau metric in normals, the red line, it's 20 seconds. You look at it in this blue line in a concussed, or actually in this situation, it is not in a concussed patient, it's in a patient with carotid stenosis. It's 40 seconds, it's longer. What did we see in concussion? You can see the difference on these images. You just look at them. This is the control, this is the patient. Now this is in the first week of concussion. We referred 20 controls from the Hull Ellis Clinic at this institution, and we recruited age-matched 20 controls. And look at how these curves have shifted. These are the control curves. Everything is shifting toward faster speed of responses. And if this line is 2 standard deviations, which is a pretty good cutoff, you get ROC curves here of 0.93. So for my intents and purposes, I don't know of any better test to detect acute concussion in the first week. So in summary, and I talked with Dr. Kozlowski, and he's doing some terrific post-processing. Dr. Malgin's doing some terrific post-processing. If we added these techniques to this simplistic method that I'm using, I think my brain's going to explode. And of course, Dr. Tatter is here. He's our neurosurgeon. I'm presenting this in a hospital environment. He can put my pieces back together again, maybe. Anyway, cerebral blood flow regulation is disrupted in concussion. CVR is increased in acute concussion. Disruption is unique compared to other disorders that diminish those CVR metrics. Imbalances in sophisticated flow control mechanism. We don't know why this is happening. It could be direct physical injury to the complex blood flow control network in the brain parenchyma itself, modulated by neurons and glial cells, or it could be these projection fibers coming up from the autonomic nervous system. And what we do know is that patients with traumatic brain injury have generalized dysautonomia. That's very well known. So this evidence supports further investigation of CVR as a potential biomarker for acute concussion, and thank you for your attention. Wow.
So,
No questions.
that is, if you're correct,
If.
that is revolutionary to be able to advocate for a test that tells positivity in a single concussed patient. That's the claim, right?
That's going to be the claim. And this is just our first run at the data. I got it last night at 9 p.m. So there's low bar analysis we're going to do too.
So that's a pretty substantial claim, and now you'll have to prove it. So if you're correct, you shouldn't need more than, 10, 20 patients to be sure?
Well, we're doing more than that. We're not stopping. We're going to just continue to collect these patients. I'm continuing to get funding to increase. Our relationship with the Hull Ellis Clinic is excellent. They're sending our patients within 1 week of concussion. We've got now 17 data points at 1 month, and we've got about 12 data points at 12 months in these same patients. And I'll present that data next year if I'm good enough to be invited to this meeting next.
And is it risk-free?
Okay, we've done 1,000 patients with the most advanced cerebrovascular disease you can imagine. I just showed you one of those patients. They had no internal carotid supply to their brain. So after having done 1,000 patients, we had one untoward event, which was a seizure. And that was controlled, and there were no permanent sequelae after that. So I have about 1,000 patients, and I can make that claim in.
Thank you very much for the presentation. Do you think, this technique would be only to grade them or like yes or no? Or do you think with time we'll be able to grade the type of concussion?
Well, this goes to what I think Joe Malgin was talking about. These are concussion patients diagnosed in a clinic using, a physician, and we also have neurological scores, which I have not employed in this analysis. But nevertheless, I think it is going to be that kind of a test if we can continue to show, and other people can, like we've already reproduced the data from one other group, and they had a 0.88, but they did not use this tau measurement. They simply looked at the magnitude of the response, and it was greater. So how much does how high do the vessels open? We looked at how quickly they opened. Combining those two metrics might actually be quite interesting.